we are going to start talking about the respiratory system, and we're going to do a brief review of respiratory function, although the book goes into great detail. We're not necessarily going to go into that much detail because hopefully you had that all in A&P and it's all fresh in your mind. Okay, maybe not, but we're going to talk a little bit about the normal function of the respiratory system, review that, and then we're going to talk about some of the common symptoms of respiratory disorders. The second part we'll be talking about infective respiratory disorders. Then we'll talk about obstructive respiratory disorders and restrictive respiratory disorders. So those are sort of the three categories that we're going to talk about. So, of course, the respiratory system provides mechanisms for transporting oxygen from the air into the blood and for removing carbon dioxide from the blood and back out into the air. We need oxygen for cellular metabolism, and the respiratory system is the only means for acquiring oxygen. Carbon dioxide is a waste product from cellular metabolism, and it functions in our acid-base buffering system to maintain that acid-base balance in body fluids. Remember all that from last quarter? Of course you do. So there are really two anatomical areas of the respiratory system. The upper respiratory tract, which includes all of our resident normal flora that we talk about, and the lower respiratory tract, which is sterile, meaning it doesn't have any of those bacteria or other flora in there. And when they do get in there, that's a problem. We end up with pneumonia. So we'll talk a lot about that. So the upper respiratory tract is the nasal cavity, nasopharynx, the tonsils, which are lymphoid tissue, so they're part of the immune system, the oropharynx, larynx, and trachea. So we're not going to go into detail about the anatomy of this because you already know this. The epiglottis protects the opening into the larynx so we don't inhale food into our lungs. That's part of the coughing and vomiting reflexes involve the epiglottis, so we don't aspirate anything. The bronchial tree continuously branches into smaller and smaller branches, ending up in the alveoli, which are lined by little single-cell epithelium and some surfactant, which is the stuff that keeps the inside of the alveoli from sticking together to reduce the surface tension and maintain that inflation. That's our endpoint for inspired air and the site of gas exchange. So pretty important. You can think of the surfactant as being, you know, like when you're at the grocery store and you get the plastic bag and you can't get it open because the sides are stuck together. Well, the surfactant helps prevent the sides from sticking together. So when babies are born prematurely, they haven't developed that surfactant yet, and that's a problem because they can't keep their lungs open. So when they know that a baby is going to be premature for whatever reason, a lot of times they will give them other medication to help develop that surfactant and make it more likely that the baby's going to survive. So ventilation, we talked about this in kinesiology, you talked about it in A&P. Now here's another time we're going to talk about it. It's inspiration and expiration, and the airflow depends on the pressure gradient. Air always moves from high pressure to low pressure. So the atmospheric pressure is higher than pressure in the alveoli, so air moves into the lungs. When the pressure in the alveoli is higher than the atmosphere, air moves out of the lungs. Easy squeezy, right? Okay, so the primary control centers for breathing are in the medulla, in the pons, in the brain stem. We have chemoreceptors, which are nerves that detect changes, they're sensory nerves that detect changes in carbon dioxide level, hydrogen ion, and oxygen levels in the blood or cerebrospinal fluid. So we have central chemoreceptors in the medulla and peripheral chemoreceptors in the carotid body. So they're constantly basically checking our blood gases, if you want to think of it that way, and deciding whether or not we need to inhale or exhale. So the normal cycle we have increased partial pressure of CO2. It stimulates the chemoreceptors in the medulla, which stimulates the inspiratory muscles, increases the respiratory rate, removes more CO2 from the body. Decreased partial pressure of CO2 causes decreased chemoreceptor stimulation and slows your respiration, so it retains more CO2. You see how that goes, right around the cycle. So really that, our reaction to CO2 has more to do with stimulating those chemoreceptors than our reaction to oxygen. Hypercapnia is increased levels of carbon dioxide in the blood. And carbon dioxide easily diffuses into the cerebrospinal fluid. It lowers the pH and it stimulates the respiratory center, which increases the rate and depths of respiration and causes respiratory acidosis. Hypoxemia is a marked decrease in oxygen, and the chemoreceptors respond to that. So, for people that have chronic lung disease, their hypercapnic response isn't working as well, and so that hypoxic drive is much more important for them to stimulate that inhalation cycle, which is why there's usually limits on the amount of oxygen they can be on. You can actually kill them with too much oxygen, which is ironic, actually. So the hypoxic drive is basically your body doesn't respond to CO2 as well, and so it's O2 that stimulates the peripheral chemoreceptors in the carotid bodies. Hypocapnia is caused by low carbon dioxide concentration in the blood, and it can be caused by hyperventilation because you've expired excessive amounts of carbon dioxide, and it causes respiratory alkalosis. This is way back to chapter 2 when we were talking about this stuff. So the flow of gases between the alveolar air and the blood is the external respiration. Gas exchange depends on the relative concentrations or partial pressures of the gases. So PO2 is the partial pressure of oxygen, and PCO2 is the partial pressure of carbon dioxide. So each gas is in a mixture that moves along its partial pressure gradient, and it's independent of other gases. So there are like two separate systems in our nervous system that deal with oxygen and CO2, if that makes sense. So here's our lovely little pulmonary capillaries around our alveolus. So unoxygenated blood from the right ventricle gets oxygenated at the alveoli and goes back to the left ventricle to be then pumped out through the body. So it's pretty cool that it's just like one little cellular layer, one little squamous epithelial cell that is causing the air exchange. There's a little macrophage in there just in case something gets in that can help phagocytize any impurities that are coming in through the air. The capillaries are right close. It's a very tiny little system, exchanging one molecule of air at a time. Kind of cool. So the things that affect the diffusion of gases in the alveoli are the partial pressure gradient, the thickness of the respiratory membrane. So if there's fluid accumulation in the alveoli or in the interstitial tissue, which is pulmonary edema, it impairs gas exchange. That makes sense, right? The total surface area available for diffusion. So if part of the alveolar wall is destroyed, the surface area is reduced and you have less gas exchange. And the ventilation-perfusion ratio. So that ventilation and perfusion need to match for maximum gas exchange. So you have to have the right amount of blood flow and the right amount of airflow in order for it to work optimally. So about 1% of our oxygen is dissolved in blood plasma. Most of it is bound to hemoglobin. So the binding and release of oxygen to hemoglobin depend on several factors, your partial pressure of oxygen, your partial pressure of CO2, the temperature, and the plasma pH. So all those systems that we talked about for maintaining homeostasis are really important in this transport of oxygen and carbon dioxide that's so basic to our cellular metabolism. Carbon dioxide is our waste product from cellular metabolism. About 7% of it is dissolved in plasma, and about 20% of it is bound to hemoglobin. And most of it diffuses into red blood cells. So the diagnostic test that they use for pulmonary function, spirometry or pulmonary function test, it tests pulmonary volumes and airflow times. Arterial blood gas testing checks oxygen, carbon dioxide, bicarbonate, and serum pH. Oximetry measures O2 saturation. You did that in acute care lab last quarter, and you'll do a lot in the future. Exercise tolerance testing is done for patients with chronic pulmonary disease. Radiography, so they help evaluate tumors and infections, so x-rays of your lungs basically, chest x-ray. Bronchoscopy, they put a scope down into your bronchi and they can perform biopsies or check the site of a lesion or bleeding. Culture and sensitivity test of the sputum for presence of pathogens and the sensitivity of the pathogen. So the general manifestations of respiratory disease, sneezing, which is a reflex response to irritation in the upper respiratory tract, it's trying to remove the irritant. It's trying to sneeze that stuff right out of there. A lot of times it's associated with either inflammation or foreign material. So you inhale pepper and you sneeze to get it out of your nose, basically, before it gets down into your lungs. Coughing, sometimes it's caused by irritation caused by nasal discharge, like that post-nasal drip. It can be caused by inflammation or foreign material in the lower respiratory tract. We're trying to cough it out of there. Or it can be caused by inhaled irritants. So sputum, you know, there's always that moment in time that when we have to talk about sputum. And then the digestive thing, we're going to have to talk about vomit, so I'm sorry about that. But a lot of times when they're testing sputum, they are looking at the color and the consistency of it. So if your sputum is yellowish green and cloudy and thick, it's often an indication of bacterial infection. Because remember when we were talking about bacterial infections, how pus can be an indication of that. So yellowish green cloudy sputum, also an indication of bacterial infection. Rusty or dark colored sputum is usually a sign of pneumococcal pneumonia, and that is blood usually. Large amounts of purulent sputum with a foul odor can be associated with bronchiectasis, which is it's like a spasm, a bronchospasm. Thick, tenacious mucus can be associated with asthma or cystic fibrosis. The congestive or obstructive pulmonary diseases. Blood-tinged sputum may result from a chronic cough, or it could be a sign of tumor or tuberculosis. So much as we don't want to talk about sputum, it can indicate a lot of things. Hemoptysis is coughing up blood, basically. So bright red, blood-tinged, frothy sputum is usually associated with pulmonary edema. The characteristic breathing patterns of respiratory disease, eupnea, so anything that ends in pnea, pnea, has to do with breathing. So eupnea is normal breathing. So U is good, eupnea is normal breathing. Chasmal respirations are deep, rapid respirations. They're typical for respiratory acidosis, and they may follow strenuous exercise. So those aren't necessarily bad, following strenuous exercise, but it can be a pattern, a specific respiratory manifestation. So labored respiration or prolonged inspiration or expiration is often associated with obstruction of airways. So people are having difficulty getting the air in or out, associated with obstruction. Wheezing or whistling sounds indicate obstruction in small airways. So with asthma and CF, a lot of times you get wheezing or whistling. Stridor is a high-pitched crowing noise, which usually indicates an upper airway obstruction. So this is from the book. It's the little pattern of respiratory patterns. Eupnea is smooth and even with expiration longer than inspiration. Tachypnea is rapid superficial breathing or irregular rhythm. Bradypnea is slower respiratory rate, deeper than usual depth with irregular rhythm. Apnea is cessation of breathing. So when they talk about sleep apnea, it's when you stop breathing when you're asleep. Usually you start again spontaneously, but that's another subject. Hyperpnea is increased depth of respiration with normal to increased rate and regular rhythm. So Kane-Stokes breathing is usually associated with periods of apnea. So they're alternating regularly with a series of respiratory cycles, gradually increasing and then gradually decreasing. So ataxic breathing, ataxic usually means uncoordinated, if you think of it that way. So it's periods of apnea alternating with irregular series of shallow breaths. Kussmaul, that's the deep, regular sighing respirations. Could be a sign of health. Apneusis are long, gasping inspiratory phase followed by a short, inadequate expiratory phase. So you get trapping of air in the lungs. Obstructed breathing is a long, ineffective expiratory phase with shallow, increased respirations. So when you auscultate with a stethoscope, when they listen to your lungs, there are different things that they might hear, and they call them breath sounds. So rales are a light, bubbly, or crackling sound, often with serous secretions. Rhonchi are deeper, harsh sounds from thicker mucus. The absence of breath sounds can be caused by non-aeration or collapse of lungs. Dyspnea is difficulty breathing, basically. It's a subjective feeling of discomfort, and it can be caused by increased carbon dioxide or hypoxemia, and it's often noted on exertion such as climbing stairs. This is something that you might note in your note, that the patient had dyspnea with exertion. Severe dyspnea can be indicative of respiratory distress. So flaring of nostrils, use of accessory respiratory muscles. Remember we talked about that in kinesiology, the sternocleidomastoid and any of the muscles that elevate the ribs. Retraction of the muscles between or above the ribs. Orthopnea is difficulty breathing that occurs when lying down. It's usually caused by pulmonary congestion. So somebody has difficulty breathing when you lie them down, you sit them back up and they breathe more easily. That is called orthopnea. There is a type of dyspnea that's called paroxysmal nocturnal dyspnea, which is a sudden, acute type of dyspnea. It's often common in patients with left-sided congestive heart failure. It happens when they lie down and breathe more slowly at night. So a lot of times sleeping with the head elevated is important for people with respiratory or cardiac disorders, or some digestive disorders, which we'll talk about. Cyanosis is a bluish coloring of skin and mucous membranes caused by large amount of oxygenated hemoglobin in blood. If somebody is cyanotic, you need to get them on oxygen, you need to get the nurse in there, or if you're in an outpatient clinic, you need to get them to go to the emergency room or call 911. This isn't a good sign. Pleural pain results from inflammation or infection of parietal pleura. Friction rub is a soft sound that you'll hear when you're auscultating with a stethoscope it's produced by rough, inflamed, or scarred pleura moving against each other. Clubbed digits, so the fingers are a little bit swollen. That can result from chronic hypoxia associated with respiratory or cardiovascular diseases. painless, firm, fibrotic enlargement at the end of the digits. So just like it sounds, they're clubbed, so you have like this little enlargement at the end of the finger, and it's chronic. It happens over time and it stays there. So hypoxemia is an inadequate oxygen in blood, and hypercapnia is decreased carbon dioxide in blood. Increased carbon dioxide in blood. Hypocapnia is decreased. So this table is from the book, and it's basic therapies for respiratory disorders, and they talk about, let me tell you what page that's on. It's on page 284. They talk about all sorts of different therapies. So like avoiding irritants, current immunizations, humidifying the air, moderate exercise, all the way down to surgery. So you can take a look at all those different things. It has the treatment, the effect, and the example. So obviously the things that we're going to do involve moderate exercise, breathing and coughing. We might be coaching people on breathing and coughing techniques. Chest physiotherapy. We might be administering oxygen in certain settings. All of the drugs, of course, those are done by their doctor. And the surgical interventions, of course, as well. So some of the therapies we'll be involved in, other ones we will be not involved in, but it's good to know why they do them and when they do them. So the primary goal of physical therapy in the treatment of patients with lung pathology includes promoting independence and functional mobility. That's the primary goal for physical therapy with a lot of disorders. We want people to be mobile. We want people to be able to get around and do things on their own. We want to maximize gas exchange by improving ventilation and airway clearance. We can do that with positioning, with breathing techniques, with posture training. Lots of different things we can do with that. We want to increase their aerobic capacity, their respiratory muscle endurance, and their knowledge of their condition. So a lot of times we're going to educate people on their condition and why this is important that they do that. So the general intervention techniques that we use in physical therapy are breathing retraining exercises, secretion clearance techniques, positioning, functional activity and exercises while we are monitoring their vital signs, and patient education. Those are all great interventions. Those are things that we can do to help people with respiratory disorders.